So in that whole process, we started preparing for the public input process, which is required with the 11 to 15 waivers, and started collecting that just in case it went that way. And then from that, CMS had a change based on some good discussions with other federal agencies regarding this particular program, and they ended up with a state plan. So through that process, we helped with a variety of authorities.
You realize when you work on a waiver, which we've done, we've written the waivers, we've evaluated the waivers, we've also written the administrative code, which is often required for the state to implement the waiver, as well as the state plan language that's often required to make an accommodation. So nothing with the block grants or other waivers or the state plan or administrative code exists in isolation. So we've addressed the full complement of that successfully for 20 years.
Thank you, Mr. Chair.
Representative Hamlin, you recognize the question.
Thank you, Mr. Chair. I was wondering on page 17 of your presentation, the statement is made under the data collections and analysis block. It says with use with data and analytical tools owned by Navigant. Could you, without violating proprietary information, kind of give us an insight as to what those tools are that gives you the unique edge?
Well, and we use our own tools for the analytics, but we do not keep those confidential. So there's no black box that we would give you the numbers and say just trust us. You would certainly be able to understand where that comes from. But we have analytical tools that we use for example, for providing report cards on physician utilization, on hospital utilization, pharmacy. We can create data reports that show by individuals the utilization of services. We can track those through time. We've developed report cards on those for a number of states, for example, for California for their managed care programs. We also have risk adjusters that we use. We have a proprietary risk adjuster, but we also use the commercially available ones or the CMS risk adjusters that we would use as well.
Okay. Follow, Mr. Chairman. Okay. On page 19, and this maybe alludes to what was asked a while ago, but it talks about on page 19 under proposed evaluation topics, verification of Medicaid eligibility. Are any individuals in the eligibility files currently on Medicaid rolls? And then it says, do all individuals meet eligibility criteria? Could you just real simply touch on how you determine or what tool you use to determine if the person is eligible for Medicaid? Do you go in and scrub the rolls, or do you use a proven method to determine that, or can you just real quickly identify how you do that?
Sure. Your Medicaid office should have rules for who's eligible for the program to give to the contractor that manages the program. So we would start there and look at a period of time, a point in time, to find out if specific eligible populations or individuals are eligible for the program.
So do you use what if there's federal requirements but difference in federal and state requirements? Do you go to the federal guidelines if there's any differences, or are there any differences?
So the instructions to your vendor who manages your program and collects the data on utilization and the population should have the business rules for that program.
We've done it for years. It's called the payment error rate measurement, the PERM analysis that determines each state's propensity to enroll people that should not be enrolled in the Medicaid program. So I've done it. But I had Catherine and her group come in and do it years ago when I was in North Carolina. Then I worked with them as a joint venture with my CPA firm and Navigant, doing that in a number of states. So we're extremely well versed, and you have to meet the federal criteria as well as the state criteria. So that's
okay. A couple other quick ones, Mr. Chair. Thank you. And don't take this wrong, I'll be kind of direct with the question. Your price is coming under, significantly some of the other ones, and so what I'm wondering is, based on the comments that were made a while ago, are you coming in at the price that you're coming in with the expectation that you could get us up to this point, and then you're going to, come back and negotiate additional, contracts if possible? And if so, how far are you going to be able to take us under this contract amount? And then do you have any expectation of how much it might go further from your perspective?
I would tell you that when this first came out, there was a conversation that Catherine and I had, and then we involved the folks from Sellers Dorsey and said, this could be a $400,000 or a $4 million contract. There was a real lack of specificity within the document. The way we priced it is to empower you to be successful. There may indeed, as a result of what we're doing, be additional work that would be merited. We would be happy to provide that, or we'd be happy to compete with it. The gentleman kindly mentioned auditing. If indeed some type of audit is required, I can assure you that the rates that would be charged by auditors to go in and pull the actual case files and do that type of detailed analysis would be much lower than the rates that would be charged for individuals like those sitting here with 20, 30 years of experience. So what we're trying to do is make sure that you are positioned to provide the greatest possible value for the dollar spent. And I'm sure you're aware of the different pricing was posted temporarily yesterday on the internet. So we know what the other prices were. We know that we were the lowest bid. I don't think that in this case paying more would get you any increased value.
Okay, and last question, you referenced a while ago an audit that's going to be coming out that we would, see some things or hear some things. Which particular audit were you referring to when you made that comment?
I was in a meeting recently that with some other several state auditors and staff, and was referred to the fact that this legislative auditor in the state of Arkansas has done some work at Medicaid, and his staff had a difficult time reconciling some numbers on the 64.
Okay. Thank you, Mr. Chair.
Sam, is you ready to ask a question?
No, thank you very much. A couple of things. One, I was in your analysis. What are you guys doing with your states now? You have, a significant number of consent decrees in place, looking at the interplay between those and ordering of spending and programs, and then obviously a little bit of a new world, right, too, and moving forward on that. And I didn't see that. Did I miss that in your proposals or the analysis of any consent decrees of federal judicial orders?
We have, we are aware of states where there are consent decrees and the need to work around those and to be in compliance with those. And we have helped design programs around those, trying to make the most in terms of any cost savings issues. And some of those, consent decrees, the result is that we have to be aware of those in the design of the program, but they're not as, there's still the opportunity to apply good business practices, good medical practices, utilization review, medical necessity review in many of those cases. In some cases, the order is very punitive, and in others, there's still room to work with those. Navigant does a lot of litigation consulting on behalf of state agencies, and so many of us are aware of the issues and the challenges around that. And certainly we are aware of that and work with that to make sure we're not recommending something that would be in direct conflict with that.
So Dave, have you ever worked with states like work to get them out from underneath the consent?
And actually,
Yeah. Yes, we have.
we have.
Well, we have 27, so.
We recently did a project for the California Department of Corrections. Their behavioral health services have been under a consent decree after consent decree. And we went in and we helped them redesign the programs for monitoring and screening prisoners in terms of their need for medical services, developing policies and procedures, helped them provide information to the court monitor, and continue to provide support in terms of that. And that's been a huge project.
Excuse me, again, for the slow learner group, would you just describe a little bit the idea of consent decrees and how they affect things? Just because some of us don't understand as much.
How about this?
Oh, sure.
Charlie, how about this? I'm making it real simple. I can speak less, so to speak. What happens is the Medicaid agency gets sued, sometimes by a provider, because they're either limiting payment or access. And what happens in federal courts and federal courts say, you know, this is what you have to do. You have to do X. It may or may not have been the intent of the state plan amendment or waiver or whatever you have in place, and it can control a lot of spending. Now, there's a recent Supreme Court decision that has come down on the exceptional child versus exceptional child case that I think the underpinnings of a provider being able to sue the Medicaid agency is now not unconstitutional. Didn't make all the consent decrees come down, but what I'm wondering is, what are you telling the other states? How are you working through this? Because it's one thing to design around the consent decree. It's another one to maybe go give it another look and maybe work to get them out from underneath it.
And the one you mentioned specifically, they do tend to very often deal with matters adolescents, particularly inpatient psychiatric services to adolescents, special needs. And you mentioned the providers filing suit. What we found is typically in the South, it's a group out of New York or New Jersey or Chicago that has filed suit on behalf of providers in a particular state. And as I'm working in other states, contiguous to you, southern states, about 90% of the time I'm trying to deal with out-of-state counsel that's still representing the plaintiff side on those issues. But we are making some progress to find long-term solutions to abate the order and to satisfy that and move forward.
I think the goal is to ensure access. I mean, we talked about that before, so I think the goal there is good, but oftentimes we see some of these consent decrees, having to be unintentional.
But the decrees can be vacated as well.
They can, and that's the question. How many of you worked on it? Let's say it's vacant.
I'm in the process on several. I have not had one vacated.
How about when you were in North Carolina?
I'm sorry, sir?
Well, how about when you were in like the Medicaid agents? I mean, did you have?
I had to comply. In fact, I'm working with several of your sister states down here trying to deal with those issues, particularly regarding adolescent services to adolescents, psychiatric developmental disability services, often in a setting outside the home. And it's tough. And one of the things that makes it tough is those settlements are often involving Medicaid dollars, but they're not Medicaid agencies. I would venture that many of your consent decrees, although they're Medicaid dollars, are actually decrees that are on the ongoing management or adherence thereto doesn't rest within Medicaid, it rests within one of your other agencies, which I would speak to Senator Chesterfield's idea that perhaps there's an opportunity for more collective and combined insight.
And we actually just had this experience in working with the state of Georgia. We helped them to develop and manage care program for their children in foster care, adoption assistance, and youth and juvenile justice. And there were 2 counties under consent decree for their foster care population. And so that rested with the Division of Family and Children's Services. So as we developed that program, we heavily involved them in the discussions and how the MCOs would have to comply with the components of that consent decree. And the ultimate hope is that eventually they'll be able to help provide that access and the number of services that are required within the time frames that are required so that they can get help.
Okay, then we have 4 more on the list here. Senator Cooper, you recognize the question.
Mr. Chair, in slide 45 and 46, somebody made a statement about a change in the federal system last year when you were on that slide, and then on the next slide you mentioned system implementation. Are we talking about the same system or something different? Or
I was mentioning new federal rules for
Right.
determining eligibility
Right.
for the non-long-term care population, the modified adjusted gross income or MAGI rules, that when those became effective January 2014. And what, as I understand it, I don't pretend to be an expert on those rules, but they permit a state to, or I guess require a state, to only look at income. Often what leads to eligibility errors and very time-consuming activities is review of assets. So under these new rules, states don't have to look at assets for those who are not applying for long-term care eligibility or spend-down eligibility. So it should, the new rules, if they've been implemented by Arkansas, I haven't researched that, I assume they have, should streamline and improve the, reduce the error rate in eligibility determinations.
Okay, so it's real changes, not two different systems that carry this information.
So the slide, for slide 40,
46, this is when you were talking about
the
the
system.
SIM.
Yes,
SIM.
so I talked about the SIM, and then I also talked about the new case management tracking
Right.
system that was implemented in 2014. So those were the two different. So there's Magi and then the new case management tracking system.
Okay, thank you. Thank you, Chair.
Surgeon General Bledsoe.
Thanks, Mr. Chair. You know, one of the things that keeps coming up is this discussion of block grants, and David, I just wanted to kind of touch base with you about this. I've been talking to a lot of people about it, and everyone's unanimous, this will never happen, this will never happen. But what's interesting is the first thing that the governor and I did after he was sworn in is flew to DC and had a meeting with the secretary. And Senator Hendren and the governor asked her directly, what do you think of a block grant? And she didn't refuse. Now that might have been political strategy and negotiation, but on some other things that we asked about, they said, well, we can't go there, we can't go there. But on the block grant, when it was discussed, it was left open. So having said that, if there's the possibility we could get a block grant or block type grant, two questions. Number one, do you think that your group has that expertise to help us with that? And then number two, do you think that that would be something that would be advantageous for the state?
Yes and yes.
One other question, Chair. That's okay. The other question I have is, one of the big issues we've had with prior consultants on other issues is obtaining the data that they need from our state agencies. Some of these computer systems are very complex. It's hard to get the information in real time, and the turnaround time for obtaining this data can sometimes be weeks to months. Seeing that we're on a very tight schedule, how confident are you can get the data that you need from DHS or the other state agencies that are involved?
We often rely on state data, and we can be very precise in terms of our data requests, and we can work with the individuals who are at the state to make sure that they understand that request and provide us the data. We try to be as all-encompassing as possible in the data request so that we can do whatever manipulations we need to do afterwards. So we're not asking somebody in the state to do a lot of the adjustments to the data or refinement of the data that we can do ourselves. But we have the capability and the capacity to manipulate very large chunks of data once we get that information. So assuming everybody is cooperative with us, I believe we can get the information we need as expeditiously as possible.
It's not unprecedented, though, that we would have to go work with your NMIS agent or the fiscal intermediary and help them access the data or with your state. But often that serves as a teaching opportunity for the state staff. We're working with a very large state, a northern state, that cannot get data out of its own system. And neither can the decision support system, which runs the data warehouse.
And that's factored into your budget, the current budget, you believe you factored in that we might have to.
If worse comes to worse, we can take it out in a very rudimentary form, and then our technical experts can manipulate it, and we can make it what we need. Our hope would be that we can request an extract that would be kind of perfunctory and would not be problematic, but we can work. The budget includes having to work around those issues as they come up.
Great. And one other follow-up question for you, David. As far as the block grant is concerned, can you explain to us why you think that it would be a good thing for the state if we're able to get it?
Well, that would require me to speak not as a representative with Navigant, but would require me to speak as a citizen mostly. But I can tell you that as a Federalist and a student of history, I'm a big fan of states' rights. And I'm a big believer that anytime we can push the decisions down to the folks who are dealing with their population, it's more effective for the state, but more importantly, it's more effective for the often most fragile members of society that you're trying to address through the Medicaid program.
I'll add the consultant perspective.
Sure.
I think given where Arkansas is and doing a lot of innovative things, and I think your probably on the right trajectory in terms of where costs are going. And I think a block grant gives you some significant flexibility, assuming that it truly is a flexible option to do the kinds of things that you want to do and continue to preserve access and redesign the program.
Great, thank you very much. Representative Murdoch, ask a question.
Thank you, Chairman, and thank you all for your presentation and being here today. It's so easy sitting over here to you all become the chosen versus an applicant because you bring so much knowledge and experience, and we're looking for so many answers. So a lot of times our interview, somehow in your presentation, our interview sometimes becomes a consultation. But I got to slide back to the evaluation part because we're still trying to choose someone. And so let's go back to your number. Your price indicates, as you know, you have a lower price than anyone that have submitted. But there is some interpretation of your conversation that says there's more to come. That you've given us a price for this much, but really to get where we're trying to go, we may need this much. Let's go back to the conversation of audit, which in your case sounds more like a review. There's a difference between audit and review. We need audit probably as us 16, we're seeking real data, real differences. The chairman talks about this many are eligible, this many are not. Those are real issues we're trying to work out to make final decisions. But what you talked about was a sample with some degree of plus or minus of difference. Do you feel like with the prices you've given us at the roughly 600,000, that it's going to give us the confidence as is to have the information that we need to make a decision? Or my interpretation has been, and I want you to give you a chance to clear it up with me, that you've only given me this much to really get where you need to be. As I said previously, we're going to have to do something additional, and you'll work with our people to do that, but it sounds as though there'll be an additional cost for that. So, and you said that there was some ambiguity in the RFP to some degree. It wasn't as clear maybe, I don't know, but that's my question. Is my 600 going to get me really where we need to be as a committee and give us the level of confidence that we need to make a good decision?
The term audit is often misused. When I was the CFO of the Medicaid program, I thought that an audit meant an analysis under generally accepted government auditing standards, GAGAS, or AICPA standards. But the federal government and states often use the term audit as it rightfully should, as a retrospective analysis. If you want a generally accepted government auditing standard, a yellow book audit, you need to require a CPA firm, not one of the firms that bid, to come in and provide you with a GAGAS audit. The problem is you'd have to define what the scope of work is for the audit. There would have to be an audit program. You would either have to do it under agreed upon procedures, or you would have to do it in order to meet some predefined standard. So I would tell you that I don't think you need an audit. I think what you need is someone with the skills, insight, and experience to look at your program, to find where there are issues. And then if those issues warrant, post delivering the report, if they warrant further investigation, then we can discuss that. But I think I've worked with U.S. senators, congressmen, governors, leaders such as yourself across the country, and I often find that people overscope and get a whole lot of busy work to afford very little insight. I think what you need is the insight and the executive summary, the ability to make decisions based on sound information.
And respectfully, certainly not to deep debate, but to try to give you where we are, we've entered into an arena that uses the word audit that now you've kind of redefined. We also have heard today the term uncompensated care. There's many definitions for that. So again, remember who you're talking to. You're talking to lay people that do different things. And again, I can't argue your argument, but audit is in the prospectus. We're expecting an audit. you say you don't think we need an audit, or if we need an audit, we need another audit defined in a different way.
As we define audit, that would be what you need. I don't think you need it generally, and I would, my colleague here who work, who's an attorney, what you do not need a generally a yellow book audit. The Government Accountability Office publishes standards for government audits. You have to be a CPA firm to do that.
I don't think that's what we mean.
So it seems to me like we're talking about, we are talking about doing an audit as you defined of the Medicaid programs. I think where there is one exception is that we recommended that you do a sample of the eligibility files, and that's the only portion of the audit where we're thinking less probably than one time you say that. And the reason we said that was because, you know, generally when you do an eligibility review, what we price out is we do a target sample, and we first determine the error rate before you decide what the pools, you know, how much you have to determine the error. And we did not price the full review of every eligibility file. I think that's where there's probably an exception in the audit discussion. And it's certainly something we could do, but we felt that it was premature to make a decision that you had to look at every eligibility file.
Especially with the change in requirements under the MAGI, the eligibility criteria are far, far more simplistic than they ever were before. It used to take us 90 days. It was a tough process to go through those eligibility files. But now that it's under modified adjusted gross income is the criteria for deeming eligibility, it's a much simpler process. I think I failed somehow to communicate more eloquently. You and I are on the exact same page. We're going to provide you the audit. We're going to provide you with all the information you need. And I don't think that there's a need for the much more expensive type of work that you do.
Okay, so to summarize, and I'll be done, I guess, for now, is that I'm confident I'll get what I pay for, we'll get what we pay for, but is what we pay for adequate for what we need? That's my question, and I think you've done the best to answer.
No, not only absolutely, but you were very astute in asking for this at this time. This is the right time to do this work, and we're the right firm to do it at this price. You guys are, other states should follow your lead and make sure that the Medicaid programs they've inherited are founded on the right data and the right formulas, and not just continue to trust that consultants in the past were magicians and soothsayers and could magically anticipate the future. What you've asked for is timely and appropriate and a perfect opportunity.
I just want to go back because I think you asked a question about, you know, are we pricing something and looking for additional work? And I think what Dave said was when we looked at the RFP and read through the asks and the questions, we did a lot of that work before we wrote this bid. So we asked a lot of the questions that we would have charged you for before we wrote the bid. You're getting senior staff who aren't going to give something to a junior staff and say, go and work on this and give it back to me and let me charge you additionally for all these conversations that I have to have. That's not in our bid. We've given you folks who can look at the issue, digest the issue, figure out what needs to be investigated further so that we can make you realistic, practical decisions to redirect, if you will, your program. And so no, we didn't bid in the hopes of adding additional work because we're going to get you to a certain place and then ask for more. We've done an investigation on our own prior to submitting our proposal that says this is what we think they need. We've looked at a lot of your material online, we've looked at a lot of the states, we've looked at block grants, so we know what's available to you. Some of that still needs to be done, but I think we've given you a bid that's representative of what you've asked for.
Okay, Senator Irvin, you're asked for a question.
Thank you. Over here. I may have missed some of the answer question. I had to flip out, but thank you for your presentation. One of the things that struck a chord with me was when you talked about we talked about the facts on the ground. So we've had a big policy change through the Affordable Care Act. We've had a lot of states do a lot of different types of things, whether it's reforms of all different kinds. But as Mr. Mosley pointed out, there's a shift in uncompensated care of bad debt. Lots of people that selected the bronze plan now they don't have the cash on hand to pay for the services rendered, whether it be at clinics or whether it be at hospitals. To me, that's indicative of just having a pulse on the reality of what's going on with those policies as it hits the ground. And so my question is, have you actively looked at and engaged in the states that you're working in looking to see where those changes and adjustments have to be made, and then how you could address that? Because I think all of that factors in to how we create an innovative atmosphere here in Arkansas, because I'm not interested in what's been done or using a formula that's worked or may have worked in other states, or it just looks good on paper and this is the policy, because you read journals, you read economy magazines, you read all those different things, and they will continually highlight the problems that are existing because of the policy, because it may look good on paper, but when it hits the ground and it's actually implemented, it's hurting people. And so this is kind of my last question for the last group was, there's a difference between cost and care. There's a difference between an executive branch to look at things and a legislative branch. And so my question is, and I appreciate having a pulse on that, because I think that's inherently important. So have you looked at what has been your experience in the other states that you have worked in, and how have you made those adjustments or recommendations?
Well, one of the, we talked about that we have a provider practice, and it's our provider practice who shares with us a lot of this circumstances in other states. And in particular, some states you have hospitals that are buying in premiums for individuals so that they can get coverage, and so they pay the cost of the premium, and they're still dealing with the issue of bad debt. And so we hear a lot of those, especially with a lot of the safety net providers and academic medical centers. So certainly we are tracking that and understand the issues. And we also have heard and also have had discussions in some states with hospital associations who are now looking at the new waivers as a way, and going to the states and saying, going to state administrators and saying, well, this is a way for us to reshape our program, redesign the benefit package, maybe get rid of the bronze, and and take a look at the metals that we're offering to make sure that we can address some of those. So the questions that you raise are very timely. I have not seen anyone successfully addressing all of those now, but I think some of those issues are just coming to the forefront, and there's certainly a lot of discourse around those topics. So we'll continue to monitor those, and especially in the states that